Hi, this is Dr. Debbie Dowell. I'm a senior medical advisor at the CDC's Division of Unintentional Injury Prevention and lead author of the recently released CDC guideline on prescribing opioids for chronic pain. So in 2014, which is the most recent year for which CDC has data available, we knew that 129 Americans lost their lives every day to drug overdoses. Of those 129, at least 78 were due to either prescription or illicit opioids, and more than half of those, at least 40, were due to overdoses related to prescription opioids. This compares to about 92 deaths per day in 2014 related to motor vehicle crashes. So since 1999, overdoses related to prescription opioids in the United States have quadrupled. Also since 1999, the amounts of opioids prescribed in the United States have quadrupled, and there's a very close correlation between prescribing and overdose deaths. So starting as early as the 1980s, there was recognition that pain, even pain at the end of life, cancer pain, could be undertreated, and there were efforts to increase recognition and management of pain, including appropriate efforts to improve pain care at the end of life using opioids and other modalities. The problem was that we got ahead of the evidence on benefits and risks of opioids when used long-term for chronic pain. There was a lot of optimism that these drugs would work as well for chronic pain as we'd seen them work for cancer pain at the end of life. However, most of the efforts were really based on very small, limited studies, most notably a study in 1986 that was a case series of 38 patients on relatively low dosages of opioids. And from that study, it was assumed that opioids could be used as safely for chronic pain as they could be for severe acute pain or pain at the end of life. However, opioids have certain unique properties, such as tolerance, that mean we can't just apply the results that we see when we use opioids short-term to their effectiveness and safety long-term. Many patients require higher dosages of opioids over time to maintain effectiveness, and we also now know that risk for opioid use disorder or addiction and risk for overdose is related to duration of use. So we don't have a lot of great, robust studies on that, but we did find 3 studies in primary care settings that showed anywhere between 3% and 26% of patients prescribed opioids in primary care settings for chronic pain struggle with addiction. Again, we don't have head-to-head studies, and didn't comment directly on the comparison of addictiveness between these drugs and heroin in the paper. But what we can say is that these drugs are chemically similar and act on the same receptors in the brain and can trigger the same reward systems that can facilitate addiction. So I would say the most important principles in our guideline are, first, consistent with the Hippocratic Oath, do no harm. Given limited evidence of effectiveness of these drugs and accumulating evidence of risks, opioids should not be first-line or routine treatment for chronic pain. Second, in the rare circumstances when the benefits of opioids for chronic pain are likely to outweigh their risks, opioids should be used in combination with other therapies to increase effectiveness and should be used at the lowest possible effective dosage. And third, clinicians should follow up with patients and determine together with their patients whether the benefits are continuing to outweigh the risks of opioids, since we know that the benefit to risk ratio can change over time. Often, these drugs are just continued simply because they have been started, and it's important to reevaluate over time whether it still makes sense to continue using opioids for chronic pain. So some of the best evidence for effectiveness of treatments for chronic pain is in non-pharmacologic therapies such as exercise therapy and cognitive behavioral therapy. We actually have the most long-term studies with the most long-term results in those areas. And both of those treatments in particular, exercise therapy and cognitive behavioral therapy, have shown improvements lasting up to months after these therapies are used. Generally, the most effective treatment is going to be multimodal treatment that uses pharmacologic therapies in combination with non-pharmacologic therapies, and most patients will require some pharmacologic therapy. If these are used along with non-pharmacologic therapies, some of the different types of medications that can be used are NSAIDs, selected antidepressants, in particular tricyclics and serotonin norepinephrine reuptake inhibitors, as well as selected antiepileptics. So our recommendations focused on opioid treatment for chronic pain. We did include a recommendation on acute pain, given that it's often hard to sort out when treatment for acute pain ends and when treatment for chronic pain begins. And we know that treatment for acute pain with opioids may have some impact on long-term use of opioids. Given that, we recommend that opioids be prescribed for no longer than the expected duration of severe acute pain, and that often this will be 3 days or less, and rarely will be more than 7 days. We specifically did not address post-op pain, and we are really talking about other kinds of acute pain, such as ankle sprains and problems that can present in urgent care. But the American Pain Society recently released a guideline on post-operative pain management in February of this year, and they recommend multimodal pain treatment, stating that it has improved effectiveness and can reduce opioid requirements compared to single-agent medication therapy. And they also noted that opioids are not required in every case of surgery. Although our guideline recommendations did not address postoperative use of opioids, we did review a study that found that patients who are started on opioids after minor surgery, such as cataract surgery, are much more likely than other patients to still be taking opioids 1 year later. Well, we hope we see a change. These guidelines are clinical recommendations. They're not laws. They're not regulations. But we hope that providers use them to reevaluate what we know about the effectiveness and risks of opioids, to have serious conversations with their patients about these medications, and to, when using them, use them more safely and effectively. And from what we've been hearing from primary care physicians, we think they will be used and will make a difference. So I would say some of the most effective policy changes we've seen have been increasing the use of prescription drug monitoring programs in states that have mandated use of checking the PDMP, including places like New York, Tennessee, Kentucky. First, the amount of time that providers check the PDMP before writing an opioid prescription has increased dramatically. And at the same time, we've seen small reductions in opioid prescribing when these policies went into effect, but major reductions in the amount of opioids prescribed to people who are receiving opioids from multiple sources. And that's important because we know that receiving opioids from multiple clinicians and multiple pharmacies is a very strong risk factor for overdose.